So I'm going to bring back our course director, Dr. Banerjee, and he's going to take the task to really provide all the data available, I understand, on randomized trials and registries in peripheral arterial disease. So a huge task for the next 20 minutes.
I want to make sure you can hear me at the back. Are the microphones working at the back? Very good. So Dr. Shamas, as you can see, presented the data very well. And one thing I want to highlight, that despite the fact that most of the presenters are interventional cardiologists, we want to provide a very fair and balanced view of the data. And in that theme, I'm going to take a very critical look of the data currently available for peripheral arterial interventional trials. My disclosures again. The reason we are talking about peripheral arterial disease is because this is not at the fringes of our practice. I can tell you this is going to become the mainstay of our practice, and for many of us, it is already taking up to 35% of all the procedures we perform. And simply for the reason from this recent Lancet publication that the estimated number of patients with this disease is going to exceed 202 million patients. I'm going to talk about early detection studies, medical intervention studies, and some endovascular specific issues that interest me, and hopefully I'll be able to interest you. To start with, the easiest and the most cost-effective way of detecting peripheral arterial disease is to perform an ankle brachial index. You'll see very rarely cardiologists prescribe cheap tests. This is one of those. You take a blood pressure in the brachial artery, and then in the ankle, you take the highest of the two pressures, divide them, and you get an ankle brachial index. And if it is between 0.9 and 1.4, it is normal, and it is abnormal below 0.9 and above 1.4. Based upon these studies, the outcomes of patients can be categorized. As you can see, patients who are symptomatic or asymptomatic with an abnormal ABI have worse prognosis. And I'm not talking about restenosis or some very rare outcome, but about survival. So presence of peripheral arterial disease, whether it is symptomatic or asymptomatic, portends a poor outcome in terms of survival to these patients. And based upon these recommendations, there are a litany of suggestions when this test should be done. And I will leave that for you to glance and also refer to the PDF on the website. However, the US Task Force for Preventive Studies does not recognize this at this point as a valid test to be used in patients in addition to traditional risk stratifiers. And we have tried to address this issue, is that what difference does it make when a patient comes to you for coronary artery disease is to measure his ABI, something like you would test them for diabetes. And let me show you some of our data. First of all, abnormal ABI diagnosed peripheral arterial disease is quite prevalent in patients referred for cardiac catheterization. As you can see, over 50% of them may have an abnormal study. If you classify patients based on the presence or absence of diabetes and peripheral arterial disease, as you can see in the bars, the right blue bar of all those subgroups show increased outcomes of major adverse cardiovascular events when an abnormal ABI is added on to the presence or absence of diabetes in patients with established heart disease. That's the key differentiator. There's a different way of looking at the same data. Let's switch on to medical interventions. First of all, this is data from the REACH registry, which shows that patients with peripheral arterial disease are undertreated, and that is the reason why, with the support of NIH and industry, a lot of preventive studies and secondary prevention studies are ongoing right now to improve this. One of our colleagues, and I'm very proud to be associated with him, Dr. Dharam Kumbani, presented his data at the European Society of Cardiology 2013 late-breaking trial, where he for the first time showed in a very large group of patients that using statin therapy appropriately in patients with peripheral arterial disease lowers their limb-based outcomes in addition to cardiovascular and mortality benefits. We are looking at aggressive regression of atherosclerosis, and we have recently done a coronary study where we have introduced LDL apheresis to remove rapidly LDL from the system of a patient within hours. And we have shown for the first time that by performing LDL apheresis in the graph below, you can have sustained lowering of LDL beyond just the few weeks after treatment, with potential benefits in terms of atheroma coronary regression. Future studies are ongoing. The question is often asked, when should we intervene? When is the point where optimal medical therapy has been met and the patient needs to be sent to an interventional cardiologist for having a stent or a balloon? This question was elegantly answered by Dr. Fakhri from Amsterdam in one of the late-breaking studies at AHA in Dallas 2013, which showed that it is the right combination of optimal medical therapy or exercise therapy in addition to timely endovascular or surgical intervention that actually change the outcomes of the patient for the better. So it is not either or, but a good combination of both of these procedures. As you've heard this morning, the issue of dual antiplatelet therapy. So let me take a first critical jab at the current endovascular data. No stent trial till today, or no balloon angioplasty trial till today in the peripheral sphere has ever mandated, recommended, or somehow controlled for the duration of antiplatelet therapy in these patients. And I can see a list of studies, including ours, which is the COBRA study, which used the shortest duration of antiplatelet therapy based upon the current guidelines and reported a 30% occlusion rate of the stents. So I think this is something we need to address as days go by. The surgeons, as always, have taken the lead on this, and they performed the CASPER trial, where after 24 months nearly, there was no difference of dual antiplatelet therapy controlling for overall events rate between aspirin and clopidogrel in terms of reducing adverse outcomes. We are ourselves planning a similar study. Let me switch gears in the last part of my presentation and talk about some endovascular techniques and strategies and take a critical look at the data. Most of the interventions are performed in the longest artery of the body, called the superficial femoral artery, and you can see, and 50% of these lesions present as occlusions, as shown on the left of your screen. This is an artery which is highly tortuous, very dynamic. Each time you're sitting or standing, this artery extends, shortens. So stenting in this artery does not probably make the greatest sense. However, there are many, many stenting studies that have been done. While we are talking about endovascular intervention, the question I'm sure you all are asking, what about surgery? What about surgery? Vascular surgery has probably the most durable outcomes for peripheral vascular interventions. The reason why sometimes we opt for minimally invasive procedures is because these patients are at a high risk of cardiovascular complications, and vascular surgery in this patient is not benign, as is highlighted in the arc on the slide, saying that between 2 and 3% operative mortality over these patients when they undergo open surgical procedures. This is a graphic summary of all interventional procedures. You see the mean and the confidence interval. I can see as we go from the larger peripheral vessels that are the iliac vessels and move down to the smaller infrainguinal vessels, there's a large spread in terms of our success rates. And this is a story that Dr. Shamas alluded to, and I just can reinforce that. Many studies, including ours, has looked at endovascular outcomes in the SFA. These studies are small. They have included a small percentage of diabetics, and the lesion lengths have been very small, as Dr. Shamas said in his earlier presentation. We try to address this in conducting the first exclusively diabetic trial in the SFA interventions, included long lesions and a huge representation of chronic total occlusions. We did show some improvement with post-dilating the stents with a cryoplastic balloon, but this is not a success that we can be proud of. Look at the study arm. Still, it has a 30% reocclusion rate at 1 year. So a lot of work needs to be done. Our group, especially Dr. Pershwitz and Dr. Mohammed, have looked at stent and non-stent bed outcomes in our own registry in nearly 580 patients, and you can see there's not a big difference overall long-term or intermediate term between stent and non-stent based procedures. Like in the coronary, chronic total occlusions are extremely prevalent in the peripheral vascular area. Let me make one point and remind you what Dr. Berlakis said. 18.2% of coronary lesions are CTOs, or chronic total occlusions, compared to 50% or 56% of peripheral lesions. So I have a very pet phrase that I want to repeat today, that in the coronary tree, one can choose to be a CTO or a non-CTO operator. But for an endovascular specialist to know to treat CTOs is obligatory. It is absolutely a requirement before one can jump into the peripheral interventional sphere. There's a lot of debate about what kind of devices we should use to cross these lesions. You can use wires or specialized devices. And in our retrospective analysis, I specify that from our own registry called the XLPD registry, we see some early signs for greater success with devices compared to using straight away a guide wire. And we are going to test this hypothesis in a recently approved, but not started yet, VA cooperative study, which will include nearly 300 patients over 12 centers, which will randomize patients based upon wire or crossing devices, confirm how the device has crossed with intravascular ultrasound, and then secondarily randomize those patients to bare metal and drug-coated stents. One such study has already been done that Dr. Shamaz referred to, the Silver PTX trial, and let me take a critical look at this. As you can see, the primary randomization in this study was not between drug-coated and bare metal stent. It was between angioplasty and drug-coated stent. And if you failed angioplasty, you could secondarily get randomized to drug-coated and bare metal stent. And for the purist, and I'm a semi-purist, it still doesn't cut it. It is great data, and I applaud the company for doing this pivotal study. However, a lot of greater work needs to be done in this area, and I provided a summary of most of the currently published or presented drug-coated stent trial, and you can see in the extreme right that restenosis rate, even with drug-coated stents, is not like in the coronary sphere. It is not under 3%. It is still quite high, especially because we believe this area might not be conducive to stenting. What about drug-coated balloons? These reviews and these data have been compiled by members of my team, Dr. Sorode and Dr. David Spelber, and they have put enormous effort to put down these charts to give you a very snapshot of what the drug-coated balloon data looks like. Again, look at drug-coated balloons. The outcomes and the restenosis rates are not close to 2, 1, or 1.3% as in multiple coronary studies, but they are in the range between 5 up to 17 and maybe sometimes up to 20%. So a lot more work needs to be done, and this is simply a graphic view of the same data, which I'm going to script in the interest of time. One thing I want to bring up, if you take all drug-coated balloons, the amount of drug on each balloon is 3 micrograms per millimeter square. Dr. Shamaz said that, dose density. And if you use a 6/60, 6 millimeters in diameter and 60 millimeter in length, a peripheral balloon, and you do just one inflation, you can deliver up to 3,390 micrograms of drug of paclitaxel to the peripheral vasculature. Compare that to the amount of drug on a coronary stent. So we can certainly deliver a lot of drug dose. To address this question, our group, in close association and spearheaded by UT Arlington, by Dr. Win Kitai and her group, have devised a novel balloon which is nanoparticle coated and has got a glycoprotein 1B ligand that will attach this drug-coated particle exclusively to the area of denuded endothelium. We have conducted animal trials with this, and we have recently obtained NIH funding to continue this work in the next 3 years. You can see this balloon not only delivers the drug, but the remaining drug that is not delivered to the artery remains on the balloon, and hence we hope to minimize the drug exposure to our patients by this technology. We have conducted an in vivo study. Dr. Hao Zhu, our new faculty at the VA, has now conducted this study and is about to go into publication. He has presented this data at TCT last year, showing that compared to multitude of controls, as you can see on the screen, delivering this nanoparticle-coated paclitaxel balloon with a GP1B ligand reduces instant restenosis, and the same data can be looked at a more graphic view on this slide. To summarize this data, here is the Kitai, Howe, maybe Banerjee balloon on the top, compared to other balloons in contemporary practice. We hope to bring this to use in our lifetime, and I'm very excited that this balloon may change how we target drugs at the vascular level and bring our knowledge of vascular medicine in this area. To summarize, I've talked about prospective trials that are coming in terms of early detection of PAD, medical interventions like statins and dual antiplatelet therapy that are a must for our patients and not just stenting. And in terms of endovascular intervention, a lot of work needs to be done in refining CTO crossing strategies and newer technologies of drug-coated balloons and drug-eluting stents. Our efforts in this direction has been summarized by many of my predecessors and other speakers, but I would like to make a pitch for our registry. This is the XLPAD registry, or the Excellence in Peripheral Arterial Disease. The idea is to collect 2,100 patients from entire US and internationally and look at their outcomes long term and not limit ourselves to 10, 20 patient studies. That makes no sense. And this is the first adjudicated, so every case is adjudicated at first adjudicated registry, and for those patients and people who perform these procedures, I encourage and invite you to become part of this movement. I also want to tell you that nothing would be possible, absolutely nothing would be possible without the help and support on days and nights and weekends of my team members. There is no list here without which this group can succeed. And all you see on the podium is a demonstration and culmination of an efforts of a large group of individuals, which I cannot begin to thank, but I do feel obliged to put it on that list. And last but not the least, the patients of our Dallas VA Medical Center and the UT Southwestern Healthcare System, and that way all our patients who contribute their information for us to make good judgments in the future and treat them better. So thank you very much for your attention.